very good afternoon to everybody. It is indeed a pleasure to invite you all for this inaugural iIGF deficiency program, which is a unique program which we have developed basically, which incorporates each and every aspect of IGF deficiency. A lot of issues in terms of evaluation, in terms of assessment and management, and many of these problems are actually not really catered for in terms of appropriate manner. So what we have done is that over the next 2 hours or so, we'll focus about the various aspects of IGF deficiency, right starting from pathophysiology, which is in itself a complicated issue, to take over in terms of when to think of the conditions, which will be discussed by Dr. Neha. Then we'll take forward with regards to the evaluation, the etiology, going forward in terms of the role of IGF-1 and BP3, which Dr. Sajali will take over. Then we'll have the growth hormone stimulation and dynamic test. Dr. Riddhi will take over. Then subsequently we'll talk about in terms of management, in terms of the conventional GH therapy, the long-acting GH therapy, which Dr. Chetan will be talking about. Subsequent to that, we'll talk about pubertal modulation, the role of GnRH analogs, and the role of aromatase inhibitors, Dr. Pratik, and finally IGF deficiency. So this is going to be overall a compact program of 2.5 hours, in which we'll cover a lot of these things, starting from basic pathophysiology to the different aspects, covering different the whole aspects and gamut of this disorder. And basically, we've got options in terms of using either the growth hormone or the IGF-1 level. Growth hormone therapy is recommended for GHD, while IGF-1 therapy is recommended for either growth hormone sensitivity, which is congenital, or acquired in the setting of an anti-growth hormone antibody with GHD1A. Now, growth hormone therapy has been used for over 60 years now. It was initially pituitary derived, which was associated with the development of the prion disease, for which it was discontinued. And subsequently from that, we had the recombinant GH for the last 35 years, which has been available. And since then, it has been approved for a number of conditions, starting from chronic kidney disease to Turner syndrome, to the development of long-acting GH, now Prader-Willi syndrome, SGA, SHOX deficiency, idiopathic short stature. So the whole spectrum has expanded over time, and now we'll discuss a bit about how different formulations and different types of growth hormone are used in different conditions with what response. So very important to remember that growth hormone preparations are available in a liquid form, in a freeze-dried form. They are also available as a powdered form for the biosimilars. Biosimilars are products which are similar in terms of structure, but they are produced using a different technique. And we also have a long-acting preparation, also IGF-1, which is available in our setting. Now, the major basis which I'm using today is the guideline from the Pediatric Endocrine Society, which really talks very rationally in terms of therapy. The key aspects are that your first thing is to look at oxology, and we've discussed it in detail, that you should be short, or not growing at all to do a growth hormone test. And if your level is less than 5, you become complete, and partial between 5 to 10. Now, very importantly, as Riddhi has already discussed, if the IGF-1 levels are low in the setting of a CNS malformation, in the setting of radiation, in the setting of imaging findings, you do not need to do a growth hormone stimulation test in that regard. Dose we already discussed is that we tend to use lowest dose in children, maybe around 25. The US dose is nearly double. They talk about 45 to 50. Then the dose may increase on puberty, but this is a very debatable issue, and the guidelines do not suggest to routinely increase the dose during puberty. And then once we are talking about the bone growth, we come back to 25, and then the dose comes down. Men around 200, women 300 because of the estrogen effect, and finally in elderly, if we are treating, it's around 100 micrograms per day in that regard. Very importantly, we need to remember that everybody doesn't have the same sensitivity. Somebody who has got a lower level of growth hormone may respond well to therapy, and therefore we talk about severe GHD like malformations, like genetic defects, starting around 15 to 20 microgram per kg per day, because they may have problems at a higher dose. Mild GHD, you start off with a higher dose, and at puberty, you may theoretically go up to 45, although it is not essential. Only if the child is short during puberty should you think about that. Now, very important discussion which is always there, whether you should use a body surface area-based dosing or a weight-based dosing. Now, most people say they are pretty much similar, and you tend to have lower response if you use a PSA based dosing. But definitely if somebody is really obese, you have a 90 kg child and you don't want to give them 9 units of growth hormone, maybe a PSA based dosing will be better in that situation. Now, the growth hormone responsiveness will depend upon a number of factors. A big factor is the level of growth hormone. So it's very evident. The more severe, the better the response. Taller the parents, better the response. Higher the dose, better the response, but there is a ceiling. So you cannot say, okay, 25 is this, 50 is this, and 100 will be this. No, there will be a ceiling effect which will come up. So that's why this talk about 25, 50 seems to be a reasonable range in terms of growth hormone therapy, and earlier treatment is better. If you have to treat somebody with growth hormone, treat at a younger age. You will get better response, and the cost will be less because the weight is less in that situation. Now, one very interesting study which looked at is whether we can really use lower doses in somebody who has got a better height. And this basically comes out from all the prediction models which we'll discuss about, particularly the Pfizer's prediction model, which is very reliable in that setting. And what it says is that somebody who is with less than 1.2 standard deviation score below, you can actually use a lower dose of growth hormone to get a response. And what they say is that once you reach the catch-up, you can actually cut down the dose. So this is a good way. You are basically trailing, you are behind in the race, a student is not doing it academically well, you push him for some time and then he catches up. So you may need to give a good dose in the beginning, and then after that loading dose, like some people used to say, let's say the insulin infusion, you load and then give the dose. This is the same corollary, that you give a higher dose of GH in the initial phase and then you stabilize at that point of time. Now, there is a huge variation in response. Same individual will respond very well, the other may not to the same dose, and this is a major issue of thing. And 80%, most models are able to predict around 70 to 80% of this variation, and this may assist responsiveness, targeted therapy, and see whether the response is good enough or not. And therefore, there are prediction models available. Now, iGrow model is from the Pfizer KIGS database, which is basically the first large database from the Kabi study which you've been to, and it really provides us response with regards to the prediction. Then based on this prediction, you can decide about what dose to give. If you are having too good a response, you can reduce the dose, or you can judge your responsiveness as well in that regard. Now, what happens with growth hormone therapy is that you expect an improvement of around 10 to 15 centimeters in the first year, then 8 to 10 centimeters. The height SDS typically grows by 1 to 1.5 in 2-year period. And what you expect is that there will be some increase in bone age. But if you track your height age and bone age, your height age will improve much more than the bone age. So there is some skeletal advancement, but that's not a major cause of worry in that regards. And of course, you don't want the IGF-1 levels to be very high in that situation. Now, very importantly, you have to monitor them after 1 month and then for 3 months. Tell them very clearly that you have to treat them for ideally till the final height is achieved, but at least for 2 to 3 years to get any reasonable good response in that setting. If they treat for 3 months, 6 months, it's a waste of money in that regard. Now, a very interesting study which was done by Hasi Cohen's group, which looked into the dosing of growth hormone. So we have talked about the clinical parameters and the iGrow, and this is about IGF-1 level and how you respond. They suggested that if we titrate the doses as per the IGF-1 level, you have got a better height response. But what you see on the right-hand side is just the mirror image. So while you get a good response, your dose of growth hormone is also much higher. So maybe it is just the dose effect rather than a titration effect. But having said that, it may be a good idea for somebody who is not growing well on GH to look at IGF-1 level and titrate the levels accordingly. Now, if somebody is not growing, the first thing would be to think of alternate diagnosis like celiac disease or dysplasia. Look at nutrition, look at hypothyroidism, because we all know that growth hormone will cause stimulation in terms of thyroid metabolism, so it can unmask central hypothyroidism. Look at adherence, this is important. Look at the injection technique and the possibility of development of GH antibodies, particularly in GHD type 1, where there is a severe deficiency and you give growth hormone, the antibodies will develop. So your 10-year-old child with short stature, height was very low, peak GH was low, had a normal workup and had a very good response to GH, but on follow-up, the height velocity came down to 2 centimeters per year. This indicates that there is a GH antibody which is happening, and IGF-1 therapy may be considered in this regard. This is a rare phenomena, but something which we have to keep in mind. Very importantly, adverse effects are there, but they are reasonably uncommon. It is one of the most safely given drug. There could be some edema, benign intracranial hypertension, so there is headache, visual complaints, 1 in 4,000. So it's a rare situation. Unmasking hypothyroidism, so measure FT4 at around 3, 6, and 12 months. Slip epiphimosis, so somebody is having difficulty in walking, limb, hip pain, knee pain. Think of a SCFE, which is basically a response to rapid growth. Glucose intolerance, we have never seen, a very, very rare phenomena, and tumorogenesis is a major concern. Now, if you talk about tumorogenesis, the theoretical concern comes from what we discussed in response to Dr. Sanjay's question of giving IGF-1 in elderly. High IGF-1 or high free IGF-1 may increase tumorogenesis. But what happens with growth hormone therapy? When you give growth hormone, whether it causes neoplasia or not is a question. When you give growth hormone, you have an increase in IGF-1, but along with that, your IGF-BP also increases. So your free IGF-1 is not really going high. So you're not allowing growth hormone to run amok. On the other hand, if you give IGF-1, there is no increase in IGF-BP, your free IGF-1 will really increase, and that could be a major cause of concern. So if you look at the database, there is no evidence of increase in primary cancer recurrence. There is a possibility of a slight earlier occurrence of second tumor, which may happen. And this was a big thing which was addressed in a large European cohort of around 24,000 individuals, the SAGE study, which there was a huge controversy which was there. But the final results basically show is that there is not a carcinogenic effect, but some form of cancers may happen earlier and more. And one major concern was about meningioma in that regards, and what they found that there is a slightly high risk or a very high risk of meningioma in GH after cranial radiotherapy. So we have to be cautious. I said about spinal radiotherapy because it's not going to benefit you much. It will increase your disproportion. Be very, very careful in somebody who has received cranial radiation because of meningioma. This is a big thing we have to worry about in that regards. Now, if you talk about the Pediatric Endocrine Society guidelines, they say that IGF-1 based dosing is not being proven at the moment, but this is a very controversial area. They talk about not increasing the pubertal dose of growth hormone in everybody. They do recommend that you basically treatment is mainly in terms of growth, but then you can continue treatments later on based upon the requirements of individual. And very importantly, in terms of tumorogenesis, they talk about discussing with the family and waiting for 12 months in terms of the response. What about the recent guidelines from the Growth Hormone Research Society? So they basically say that we should go more in terms of the prediction algorithms because they help us in terms of treatment. They say that IGF-1 should be looked at, but they don't know what level should be there. So they said 0 is good enough, should not be more than 2 in that perspective. Very importantly, they've given us very good criteria in terms of responsiveness. So if your height SDS is not increasing by more than 0.3 in a year, that is significant in that setting. And think of other possibilities like celiac, like skeletal dysplasia, as we already discussed in our clinical setting. Now, the second most common indication for which growth hormone is given is Turner syndrome, basically which are very short around from the birth. They have got low growth, reduced pubertal spurt, and a 20 centimeter deficit in terms of final height. They have a normal GH IGF-1, and they also have multiple other effects. So growth failure in Turner's is because of positively insulin deficiency, of course, but also an effect of skeletal dysplasia because of a shock effect along with a growth hormone resistance. If you give a higher growth hormone dose, which is around double the dose for GHD, there will be response. Do not give a growth hormone dose which is for GHD in Turner's. That's going to be a homeopathic dose. There will be no response in that regards. Very importantly, hypothyroidism has to be excluded. So if you talk about the Cincinnati guideline, which very well talk about growth hormone therapy in Turner's, should be given if the height is less than growth velocity, less than 50th centile, and there is a high likelihood of short stature. The dose, so this is basically moving from actually short girls to a decreased growth velocity. Now, the dose is higher, 45 to 50, and 4 years before the pubertal induction is what is ideal in that setting. Of course, if this is a pharmacological indication, no need for GH or IGF-1 testing in that regards. Now, here we talk about the PSA or the body surface area based dosing, which seems to be more reliable in terms of the cost therapy. So, in turners, maybe body surface area based dosing is more appropriate in that context. You have to monitor in terms of growth. Remember, the growth is not as good as GHD. You expect a 1 centimeter per year increase in final height. From that, there will be a bone age advancement. There will be much higher IGF-1 levels here, and the target is to keep it less than 3. If your SBS is more, IGF is more than 3 standard deviation score, that is extremely high, which you have to be wary about in that regards. Think of complications like headache because they have a higher risk of benign intracranial hypertension, scoliosis, and limb. You have to be cautious about. So edema is common, raised ICT is common, and hypothyroidism. So all these, because your dose is much higher, will cause a greater effect in Turner syndrome as against other group of conditions in terms of GHD. You can also have a disproportionate increase in your hand size, nevi, and pancreatitis risk, which is important in that setting. The third indication is, of course, STA, which I would say is more important than Turner. It is very common, 2.5% of all newborns, 90% catch up, but 10% who do not catch up have an early puberty and land up as short adults. They have same implications for preterm or STA, plot on intrauterine chart till term and correct for the size subsequently. Now, SGA, the problem is that you have high GH in the fetal period, but then there is a combination of resistance and deficiency. And if you really give more growth hormone, you will have an improvement. They also tend to have early puberty, so you cannot wait till eternity because that's going to cause a lot of problem in that situation. Now, if you talk about the SSA consensus, what you have to do is to exclude the systemic diseases, look for nutrition, and if there is no response, consider therapy provided there is no contraindication like Fanconi, Bloom syndrome, which can be a problem. There is no need for a GH testing. Higher dose of GH is recommended, and the response is better than Turner syndrome in terms of efficacy. Now, there are different guidelines in the US and Europe. The US people are more aggressive. They talk about 2-year treatment, even lesser height compromise. Growth velocity is not important. By European agency, talk about older children. In India, I like to probably stick to 4 to 5 years, if particularly if the child is very, very short in that regard. So keep monitoring for their growth. If they're not growing appropriately by around 4 or 5 years of age, very short, think of growth hormone in that situation. It has to be an individualized decision as per severity, and if the puberty is really advanced, think of a GnRH analog in that setting. Now, Prader-Willi syndrome, which probably is the last indication before ISS, which we'll discuss, is a hypothalamic GH defect in which you will find that there is a GHD, and because of that, the growth is less, but there is a lot of obesity. Now, this causes a lot of problem. There is also a central hypothyroidism which has to be corrected in this setting. The guidelines of Prader-Willi is that anybody who has a genetic diagnosis of Prader-Willi syndrome, once you confirm that, you do not need a growth hormone testing and you can treat. Earlier, people were treating only for those who have growth failure, but now, if the growth velocity is less, you can consider treatment at a lower dose. Start at a very low dose because there is a risk of increasing sleep apnea and even deaths, which may happen in this setting, and then you gradually build up the dose from there. Very importantly, exclude severe obesity, diabetes, and sleep apnea because these three can cause problems once you give growth hormone in this group of settings. It can really cause psychosis, active malignancy, of course, and respiratory infections are contraindications in that setting. Finally, what about idiopathic short stature? Now, we all know that idiopathic short stature is basically a diagnosis of exclusion. It basically means that you are short, everything is normal, workup is normal, and you have excluded the other causes. So now this is something which we have not found yet, and probably over time this ISS will become more likely to have a pathology, but till then the treatment is difficult because it is a combination of growth hormone deficiency and resistance. If you talk about the consensus guidelines, it says it's a very, very liberal guideline. Basically, anybody can be treated by these guidelines, but we have to be cautious. So height less than minus 2.25 SPS after 5 years of age with a normal evaluation, you can give them growth hormone. So this is a I would say, a too liberal recommendation, because the treatment cost is huge. You expect $10,000 treatment for every centimeter gain. So this is something which we have to think about, counsel in detail before you even think of idiopathic short stature as a treatment modality. Growth hormone has also been considered for skeletal dysplasia, but now we have CNP receptor agonists, which may be more helpful. Steroid toxicity, hypophosphatemic rickets, and silver acid, which is of course like a SCA indication.